So welcome to week 8. As I told you, it's going to get rough in the end, and you're going to be overwhelmed with so much that's due, exams, worrying about HESI, grades, etc. And it has happened. This week, there's a lot due. So number 1 is that pediatric assessment assignment. If you want to do a certain diagnosis, please send it to me for approval. I want to say it's okay, because there are some times where I get all of one diagnosis. And also, I want you to be careful. These assignments are set through a plagiarism checker as you send them to me. And a lot of times I see a lot of similarities from another student from Fortis. So if you're going to use somebody else's assignment, please change up the words, put it in your words, and then you can learn from that assignment, okay? Instead of just trying to give me somebody else's, because it won't work, because I can see it. So that's a warning. It's an APA paper, 250 words. Make sure that you cite within the paper and give me 2 references, because you're telling me about a diagnosis. The assessment part, for instance, if you have chosen asthma and you're doing that pediatric assessment form, make sure that respiratory part, tell me what asthma looks like in expiratory wheezing. You're going to see that prolonged expiratory phase, coughing, et cetera, retractions. I want to see that. And don't put within normal limits. We have an endocrine system. What might you see? We have cardiovascular. How does the heart sound? Okay, that's what I want to see in the assessment. And the third part is the teaching portion. Could be PowerPoint, 5 slides is fine. Teach me something. What do I need to know about taking care of asthma? Could it be taking a puff? Could it be preventing? Or how to take medicines, whichever. Then it could be a PowerPoint, could be a brochure, or just a picture board. Sometimes pictures tell a lot. Make sure there's a reference on your teaching. Now, if you send them in early, I will look at them. If it has areas that could be improved, I will let you know where, and you could turn it back in for a better grade. So you could get perfect grades if you turn it back in and get it into me earlier. And I will be checking it through this weekend, even though it's Thanksgiving. Yes, I'm going to do that because I want you to get the best grade you can. You also have quiz 5, which you'll be ready for after class. You do have the pediatric assignment exam, 50 NCLEX questions, and you have the diabetes case study that is open, ready to go. Make sure your dosage calculation worksheets are in also. I believe most of you have them in, which was pretty cool. So thank you for that. Any questions about anything? The one thing I tell you about the pediatric assessment, pick something that you don't know about. Pick something that maybe your child, your friend's child, your cousin, your aunt, your next door neighbor had. You want to learn more about, and it makes it more meaningful, and it gives you information that you could use. I always say that. So pick a child, pick an age, and then, do the assessment from there. So let's start out with our PowerPoint, and then we do have a 54 question Kahoot, which goes over the concepts and also a couple things that I don't get to on the regular slides, but I give you the concept you need, of course, in the Kahoot. So GI-GU, I did send you a matching worksheet for this. It goes through the book, some of the really important concepts and diagnoses you need. You're going to see in the GI section a lot of things that adults don't have. So these are different things you've never heard of before. Please pay attention to signs and symptoms you see with these diagnoses, whether it's a olive-shaped mass in the abdomen, or currant jelly stools, ribbon stools. Know those things, and you'll understand as we go through this. So urinary tract infections, very common. Kids, number one, at the time that they're getting these is because we're not wiping right, front to back. When they're infants, they sit and stool, could go into the meatus, causing some infections. And boys that are not circumcised, and parents that were not pulling down the foreskin and cleaning all of that, schmegma that's underneath there. And that can cause infections too. We know bubble baths and tight underwear and those cute little leggings that we like now are actually not the best things that they should wear because it holds the heat in and creates infections in there. But the number one, I think, is teaching children front to back, not to get it, the stool up into where the urine is. And one of the things about urinary tract infections is the kid's better, looking good. It's hard to get the kid to take medicines, and we don't finish the antibiotic. We know that they need to finish it or that infection could come again. So why do we look, for these urinary tract infections? Well, we teach our parent that if you see a kid who is potty trained, who all of a sudden is not, look, smell the urine, in their underwear. It could be foul smelling. They might be itching themselves, or it might be urgency, but usually it's that foul smelling urine that says, hey, we have a urinary tract infection. You don't always run a fever with this. You don't always have abdominal pain with this. Sometimes it's just the smell. So teaching parents to let them know how to wash hands, wiping front to back. Adolescents, if they're sexually active, that after they have sexual intercourse, they should urinate, especially those adolescents who have frequent urinary tract infections. This can help decrease them. So how do we diagnose it? Well, urine culture sensitivity. Now, in infants, they're small. Remember, they have no immune system. So we don't want to treat urinary tract infection with an antibiotic, and a month later they get it again because the antibiotic wasn't correct. So we need to do a catheterized specimen. And you're like, ooh, it hurts. And well, these children are so fragile and their immune system is so, decreased. It's not built up yet. We want to make sure that we do a catheterized specimen, get a clean specimen, and then we know that when it comes back and it tells us the antibiotic that takes care of the bacteria, we know we're on the right one. So we cure it one time. Okay, so that is the most accurate way of treating a urinary tract infection by catheterizing. I mean, just think a little girl putting a bag on, right? They got all that cheese in between their labia. What are we really getting a specimen of? Is it the urine or something external? So that's why we do that. And even circumcised, uncircumcised boys, there's always a little lip of, this, even if we clean it good. So catheterize is the best. When the kid is older, yes, we can do a clean catch because they have more of an immune system, unless they are that frequent urinary tract infection. And then, of course, that one will be a catheter too. In premature infants, we do not have a catheter small enough. And they're so tiny, and I don't even know how you could see, that meatus to stick it into. So what we do is a suprapubic aspiration. The physician does it. He cleans right above the symphysis pubis bone. He takes a syringe, usually a 3 cc syringe, and goes directly down 45 degrees. And that's where the bladder is. And he pulls out about maybe a half a cc of urine. And that's all we need in order to get a culture on these children. And that's what they do. Most premature children are intubated. They're usually on some sort of sedation. So, of course, the pain is also worried about because they're sticking a needle down in them. But it is looked after. If the kidneys are always pyelonephritis, something's going on, they could do a kidney tap. Or they could go in and put a catheter in and put fluid and wash up and stir up what's in there, pull out something, that's a bladder wash. Ultrasounds look at structural problems. Is there a problem with a kink in the ureters? Is there reflux going on? We have ultrasound and voiding cystourethropographies. They'll look at that. And then the IVP is usually used for those kidney stones in the older kids, along with renal scans. Now, you've got a kid, chronic urinary tract infections, and it shows as pyelonephritis. The kidneys are an infection. Now, if we allow this to continue, the kidneys are going to die, right? So we need to do a renal biopsy. Now, when we treat for these is before they can't eat, before the test, and depending on how old the kid is, depending on how long before. I mean, newborns can go up to 2 hours before, but older kids, 4 to 6 hours. They are pre-medicated. Usually they're giving some midazolam, Versed, make them a little bit loopy, because we don't want them to be all worried and excited and, moving for this. Many of the times they give some more sedation to get them really comfortable for this, because they're literally going through their back into their kidney and they don't want them moving. And they've got to take ultrasound to see where they are in order to do this. So when they come back, you're going to take the vital signs, and just like cardiac cath, the first thing, what do I look at, is a dressing, because that dressing is a pressure dressing. It's a sandbag, just like cardiac cath on the older children. And we're looking for urine leaking, right? And it could leak either on the dressing or in the abdomen. So you're going to be checking that, abdomen for pain, discomfort, and distension, and the dressing. And of course, they could have hit a blood vessel so it could bleed. So we're looking for those things. Just like cardiac cath, 24 hours in bed, because we want that area to be clotted off so that the kidneys won't leak and it won't bleed, et cetera, et cetera. And the younger kids, because the areas are so small, they do incisions, but the older kids, they usually just do a puncture. Now, I mentioned that there's something called obstructive uropathy, and it depends on obstruction that causes it to go back in the kidneys, which causes hydronephrosis. Yet be one side, there's a kink, so it's not going down, or there's refluxes going up, one side, both sides. So knowing what's going on with these kidneys and these tubes, your ureters and your bladder, which is also called a vesicle, because it's a vesicle that holds urine, we can find out what do we need to do to prevent these urinary tract infections. And there's a pretty picture, shows what the sites are, and we see the ureters and the bladder or the vesicle, and those areas anywhere could be kinked, not functioning, not open. Nephrotic syndrome is something that happens with children, and I'm going to say something 3 times. Has nothing to do with renal failure. Nephrotic syndrome is not renal failure. The kidneys function, but the kidneys say, hey, protein, I don't like you, let's get rid of you. So as it filters through the kidneys, protein is lost. How would you see that? Proteinuria. And it looks like a beer foaming. That's how much protein's in it. You're also losing protein from the blood. So it's hypoalbuminemia, because albumin is protein. It also causes a lot of fat. And because of hypoalbuminemia, there is the isotonic and hypotonic sort of solutions. The fluid intercellular goes extracellular, and it causes a lot of peripheral edema. Could be around the eyes, the face, the tongue, the gums, everywhere, and they puff up with all of this edema. So here we are having a kid retaining fluid, okay, and all of this edema. They're immunosuppressed, so always risk of infection. So always hand wash. That's always number 1. Because of the swelling in their mouth and their gums, they're not going to feel like eating. And then how do we treat it? Well, any fluid retention, whether it is an adult with CHF, a child with nephrotic syndrome, you're going to monitor salt. You're going to decrease it. You're also going to decrease the amount of fluid that they can take because we want to make sure we get rid of that edema. And, these kids during this time, this is not something that happens and it goes away. This is a lifetime. And steroids is how we treat this. But we need to, as they're swollen and not moving, activity for that. And as they get feeling better, let the kid be as best they can. And the family needs to know how to take care of this kid. So now you're the nurse. You got a kid admitted with nephrotic syndrome. They're full of edema everywhere, full of fluid. So we are going to make sure that we prevent infection. And we're going to be monitoring their fluid balance by, the salt restriction, by fluid restriction. And we can monitor any fluid balance with strict intake and output and daily weights. That's always when you see fluid problems, strict INO, daily weights can monitor what's going on. Now, acute glomerulonephritis is the second disease caused by a strep infection. Number one is rheumatic fever, right? Acute glomerulonephritis, acute means something that happens that we can cure. Sometimes it can become chronic though, but acute is because it happened that we didn't treat that strep infection as much as we should have. What does it look like? Well, oliguric, they're not peeing. Well, if they're not peeing, they're going to swell up and have edema. And with all this extra fluid on board, you're going to be hypertensive. Makes sense, doesn't it? Then they're going to have hematuria. And of course, these guys are going to be losing proteins like crazy too. So you could see while they're swelling up, we're going to worry about infections. So this child, we're going to be treating with the antibiotic. Let's take care of it. And then we're also going to do things to monitor to get the fluid off of them. And usually these children, if we can cure it fairly quickly, will just be a one-time and their kidneys are fine, but it can become chronic. So the quicker that we get these kids to be seen, the better outcomes. So we've got fluid balance issues, right? What are we going to do? We're going to daily weights, INO. And because it's kidneys, we're going to be monitoring their abdominal girths. Are they swelling inside their bellies too? Again, low sodium. We're also going to do fluid restrictions. And just like your other one, you've got susceptibility to infections. So whenever you're put over that edge, nephrotic syndrome, glomerulonephritis, be careful. These children we should be handling with gloves on and hand washing, etc. Wilms tumor, we've talked about that, right? Nephroblastoma, it's a kidney tumor. It is boys, ages 3 to 5, African American. And this big old tumor comes. And they really don't have many symptoms. And, like I've said, I had this kid dropped off in my triage room and they had no clue. And it was, all the information was in French. So I did my assessment where I found this softball-sized tumor in the left lower quadrant. And for, I guess, some of the CEUs I did or something, I remember reading about it. And I'm like, this has to be a Wilms tumor. And it was. Now, these tumors are very fragile and they flake apart and they cause metastasis within the peritoneal cavity. So they make a big incision. They might do chemo radiation before, but even so, they're going to put a big incision because they don't want to manipulate it. They want it to come up. And remember, going through the front, where's the kidneys? It's way in the back. So we really have to move intestines around and get that kidney out and keep it in one piece so we don't put any metastasis within the abdomen. They do well, but the kid that we had actually did really well. He sent a message back to us from Haiti, so that was awesome. Renal failure can be acute, or it could be something that happens from birth, as in chronic, or it could happen acute, we don't treat it and becomes a chronic. So acute, you're just not working well. Usually it's due to infections, urinary tract obstructions. I've seen it because of ibuprofen before. The child had too much ibuprofen when it was renal failure. So that was quite intense to see that we have this child just taking ibuprofen. The mother had given him a little bit too much, and that's what happened for this kid. Chronic is usually something, usually congenital or hereditary that goes on. So acute renal failure, what do we see? Well, we're going to see all of a sudden the kidneys aren't going to work and you stop urinating. And it's not common, but the most common reason why this happens acutely is dehydration. You can see why it's so important that kids keep hydrated. Like I'm talking sickle cell and going out and playing, making sure they have fluids to drink, the electrolytes, to keep the fluid going. Because renal failure is a real and big deal, and it can happen, and it can cause acute renal failure. Sometimes it turns to chronic, but if we get it good enough, we can just replace the volume, they do well. Now, in chronic renal failure, the kid is usually born with some degree of it, and it gets worse and worse. They say more than 50% of the capacity is destroyed, and that is classified chronic renal failure. And then, of course, it deteriorates over the years, and they require dialysis. And it depends on the child, depends on the nephrologist, 2 times, 3 times, 4 times a week, it depends. So what causes chronic renal failure? Well, it could be that malformation, could be that reflux that's going on, that's killing the kidneys, that hereditary disorder. At the hospital I worked, I did some clinicals with some students on the GU floor that had the dialysis area. And they said they had a lot of families that they saw that there was some intermarriage within families, like second cousins, and that caused these deformities for whatever reason. And of course, glomerulonephritis. You don't treat that strep, guess what? It can kill your kidneys. Lupus kills any organ. And of course, any anaphylactic sort of thing can cause it. So you have a kid, chronic renal failure. We know that it's not working. The kid's going to need to have dialysis. And older kids get dialysis. The newborns will get peritoneal dialysis, and I'll go to that in a second. So we're trying to make the kidney work as best it can. And just like adults, they're not producing the red blood cells the way they should. So we need to do something to help them produce. And we give them their erythropoietin, those sub-Q injections, just like adults. We give it for kids. And kids always need to be treated like a kid. Even though they are tied to dialysis machines, they still need to be children when they can be. So this is peritoneal dialysis. Now you're like, well, why don't newborns, young kids, small kids get hemodialysis? Well, you need to have an arterial and a venous shunt. And it pulls the blood out and it pushes it back in. The way it pushes the fluid back in, there's too much turbulence. And that swooshing of that extra pressure goes to the smaller kids' heads and can burst blood vessels and cause intraventricular hemorrhages. So they can't have hemodialysis till they're older. So the great choice is peritoneal dialysis. So they put a catheter, just like this one, in there, and they have a nephrologist order some solution. They have this machine with all these tube things, and they put it on this little heating pad. So it's warmed solution called diastolate that goes into the abdomen. And the nephrologist orders 100 mLs to be put in, let it sit in there for 20 minutes, and then let it drain for 20 minutes. And this machine does that. And each time it does one put in, which is called a still, and let it sit and drain, it's called a cycle. You might do 8 or 10 cycles a night We put this on at nighttime on these infants. They're starting to do this a lot more on adults too, because it's better than being strapped to hemodialysis during the day. They can hook themselves up. Problem. You must be in complete strict isolation type of preventing infection to hook these things up and put the tubings together. Infection can kill a kid, because if you cause peritonitis, what's going to work as the kidney? There's nothing left. Their kidneys don't work. Now their abdomen is all infected. It's not going to filtrate for you. So we really need to monitor for that. How do you monitor for peritonitis? Well, the abdomen would be tender, maybe a little reddened, painful, right? And you might see that fluid that's being returned, the color change. So it was clear coming out with maybe a little yellow in it or something, and now it's cloudy. There's a problem. So what do? Well, you continue the dialysis. Call that primary care physician, and he's going to order an antibiotic. But call the doctor. Be prepared. You're going to get an antibiotic. So these abdomens are great. These abdomens work well, but we have to maintain good sterility. And if we see a change in that drainage coming, you need to get them on antibiotics. I saw this one mother treat this kid for 2 years before he got a kidney, and she never had an infection. This kid always came, it always was lubed up with grease because these kids are dry for some reason. And the dressing that she would put on every day was as good as the dressing I would put on. And I'm OCD. It was a very refreshing to see that child. So peritoneal dialysis can be monitored at home. Parents can be taught, and they can do it well. So what best describes acute glomerular nephritis? Anybody? What is it caused by?
B.
Yep, rheumatic fever, glomerular nephritis. These are caused by strep infections. Good. Now, the GI system has a lot of things adults don't have. That's why I gave you that handout so that you can connect the dots and look at them, because it is different. And some of these things you've never heard of. So GI system goes from mouth to anus. All it does is absorbs food and minerals and eliminates waste. That's what the GI system does. It helps with vitamins and minerals, and that taking those food and make it into things that work in the body, all the enzymes. But there are some things that can cause problems. Well, cancer, you're not going to want to eat, so nutrition. HIV, same thing. Sickle cell, we're going to be losing a lot of your red blood cells. You're not going to eat, not have the energy. Cystic fibrosis, this is all about that small intestines and clogging up and not absorbing your fat vitamins. And then any premature infant, you're always going to have some unique nutritional demands on them, because they can only eat smaller amounts. They need higher calories. They need different type of nutrition. Now, celiac disease. This is something caused by nutrition. You have a small intestines, which absorbs all of your things that you need, all of your nutrients. There are glutens, which is wheat, rye, and barley flours. So anything with a flour, you have to be careful with. And it creates a lot of stress and tension on these villi, and there's no absorption of food that will go on, okay? This causes a lot of pain in these kids if they eat something wrong. So the way we treat that is literally through diet. So the one thing after researching this a lot is, it's no low gluten, it's no rye, it's no wheat, it's no barley, But, there's rice breads now, and there's rice things you can have. And there's so many gluten-free things. I mean, bacon, eggs, fruit, um, you can have vegetables. I mean, there's so many things that can be done. It's just the breading we have to worry about. It's macaroni and cheese. And today they're making substitutes for all of this. So these kids have it better today, and these adults that are celiac disease have better outcomes because go ahead, walk through the bakery and see how many gluten-free things you'll see today. You didn't see those 20 years ago. Now, food allergies. We feed our infants at 6 months of age. We start those foods, cereals, fruits, vegetables. And we know that we do not introduce a new food until 4 to 7 days after we start the food. So we wait in between giving a new food. And we're going to look for food allergies. I mean, some are anaphylactic, we could see that, but some are very subtle. I mean, it might be a nice red rash like that, or it might be under the chin, it might be under the arms, the bend of the elbows or the knees. That might be what it is. But food allergies are basically an intolerance. Lactose intolerance, you would see a lot of diarrhea and vomiting, so that we would know to change the formula to a non-lactose. So GI dysfunction, what is it? Well, you're spitting up, you're losing food. That's nutrition, right? It can cause growth failure, cognitive delays because not getting nutrition. Is that spitting up, regurgitation. Could be nausea, vomiting, diarrhea, even constipation. It causes abdominal pain, GI bleeding. We know the liver and the common bile duct and the secretion of all of these enzymes. And if something's blocked, like a common bile duct is blocked, or there's no passageways, it could cause jaundice. Well, what if a kid can't eat right? They don't know how to suck, swallow, and breathe, or maybe they don't know how to chew. And there are children in syndromes. There's Pierre-Robin syndrome, has a problem with chewing and swallowing. DeGeorge syndrome, another one. They have tiny little chins and they can't work, and they need a lot of help with speech therapy in order to finally eat through their mouth. Many of those end up with G-tubes to supplement them until they can. And we know if a kid has a fever, are they going to eat? Nope. My grandson who's with me has 101.5 temperature, not eating. I don't want nothing. Doesn't want his apple juice, doesn't want his ices, he doesn't want his favorite nothings. It's because fever goes up, they do nothing. So what do? Give something for the fever. And if I can wait every 6 hours or 8 hours for ibuprofen, that's what I prefer on him. But every kid's different. Tylenol in between if I have to. And then they eat, they drink, and they do well. How do we know they're doing well? He's peeing. As long as he's peeing, we're okay, right? He's getting enough in him. As I said, dehydration is very dangerous on children. So we know it's when there's more out than going in, and it could be due to many different reasons. So infants, I love these two pictures because when I think of an infant who's dehydrated, this is what I see. A kid sitting there quiet, not crying. That fontanelle is sunk. But what else on that upper picture do you see? I see a very pale child. The nose is pale, the ears are pale. If we had a front view, I bet you those eyes are sunken. And if they happen to cry, there are no tears. That is a kid who's severely hydrated. All right, that's a visual inspection. The next thing I'm going to do, I'm going to listen to their heart rate. Where is it? Dehydrated? I bet you an infant's at 200 at least, because their heart's trying. If I took a blood pressure, it's going to be low. Volume depletion. So, if we had a longer time, it'd be decreased urine output. Then I could look at capillary refill, skin tenting, all of that stuff. So symptoms, And adults, children, does it matter? Well, we have a fontanelle and he's crying with no tears, usually only on infants. But you can see all of this stuff on any age person. So number one, what are we going to do? Well, I need to start with a basic metabolic profile. I want to know where my electrolytes are. I mean, what was the cause of dehydration? Was it diarrhea? Was it vomiting? What have I lost? Do I need potassium? And at that same time, get in this lab, I'm putting an IV in, and I'm going to give fluids. Remember, fluids that you give in bolus are never, ever with sugar, only normal saline. Older people, they give Ringer's lactate too. But in our kids, we give 0.9 normal saline. After we get results back and we see that their potassium is maybe low, then, only then, or if they urinate first, we can put potassium in their IV. And of course, if they're vomiting, they're going to get an antiemetic. Diarrhea, there's no miracle cure. It's actually give them some probiotics and eventually their tummies will get better with just probiotics. So measuring intake and output, some children are really dehydrated and we need to look at many different things, but urine and stools, vomit, I mean, are they profusely sweating after a fever when we break that fever? That is quite a little bit of insensible water loss. Vital signs are key. And then of course, skin turgor, mucous membranes, you'll see cracked lips on children, sunken eyeballs that is showing you. And of course, crying with no tears gets me all the time. And then of course, fontanelles. In older children, because lack of perfusion to the brain of oxygen, they're a little bit confused. They're sluggish. They're not answering questions as quickly as they normally do because they're so dehydrated. Now, diarrhea can be caused by many different things, but, depending on what it's treated, therefore, we're still going to do the same treatment. So, of course, we need to rehydrate. Now, if a kid has just diarrhea, no vomiting, we can hydrate orally. We can give them oral electrolyte solutions, but you need to start feeding them. Because if you only gave liquids, what's going to come out the other end? Only liquids. So we start giving them, it used to be the brat diet years ago, but we can feed them in stuff that's not spicy, no pepper, not like orange or citrus, maybe toast and rice and pancakes and, easy stuff to go down. And that really helps that stool to bind up along with that probiotic, right? Now, if the kid is very lethargic, very dehydrated, and that's going to depend on the heart rate and of course their mentation. Are they alert or are they a little incoherent? Then we're going to do IV rehydration, but mostly it's just given something by mouth. We would give them Pedialyte or Powerade, and then in between maybe a popsicle because, at least they're getting fluid, right? Constipation. Now, constipation could be due to many different things, but I want you to know that children, the only thing they can control is their stool. And sometimes due to severe stress and emotional something, I've seen them go 7 to 10 days. No bowel movement. I can't imagine. And then you take this x-ray and the whole bowel is white and full of stool. They're going to get an enema like now, okay? But it's the one thing they control. The one thing about constipation, when you have frequent urinary tract infections, it could be due to not having stools because you bear down and then you're wiping and that bearing down causes problems. And then you're, the urine, you're pushing and that causes, bacteria to get up in there. So the first thing they do with urinary tract infections, those chronic, is monitor stools and getting them flowing a little bit better. And they want it nice and loose. They don't want these hard bolitas like these are called here. We don't want balls of it. We want it to be nice and smoother. Now, you're a newborn. You've been born, it's been 24 to 36 hours, and you are not stooling. It should look like this one here. This is a first stool called a meconium. And it's gooey, just like it looks. It's sticky and gluey. And it's like black green when you look at it closely. You don't see that, something is wrong. Well, number one, is there a blockage? It doesn't mean the intestines go to the anus. I mean, all right, you have an anus. You got to check that first. Some of them don't. So, all right, you have an anus, nothing coming out. Could be a blockage or a narrowing, stenosis, atresia or stenosis. It could be Hirschsprung's disease, and that's no nerves. And we're going to go in that in a little bit. I'm going to teach you about that. How about this? Hypothyroidism. Constipation, you've heard about this in adults. Well, newborns, it might be the only time that you see it that you can catch it. And we know giving newborns that thyroid hormone is imperative for cognition because they can get mental decline without thyroid hormones. And then the other thing is cystic fibrosis. So when you don't see a stool, they'll do an x-ray and they're going to test for thyroid, all the hormones, and they're going to be testing for cystic fibrosis, your sweat test. Now, sometimes kids are eating and it's just normal type of constipation due to diet. Now, breastfed infants usually have multiple stools a day. It just tends to be looser. And it actually depends on mom, what she's eating too. But infant-fed babies tend to have more solid. It tends to be harder. And they usually have more chance of getting constipated. So how do we treat it? Well, usually the doctor, even in younger kids, will say, give an ounce of apple juice or give a couple bites of prune fruit. Even though they're not going to absorb it, use it in their GI tract, it's going to make them move. Just like prunes, apple juice could do for you, they could do it with the infant. It's just to move it. And they can get a little glycerin suppository, just a little piece of a chip off of it. It comes pretty big, so you have to take a tiny piece. Or if it gets to the point where the whole thing, the x-ray is showing this bowel everywhere and stool, they can get an enema, but they don't want to try to do that too much. They would prefer more of a natural way so they don't get dependent upon it. And as the kid gets older, they might enter Miralax, this slight laxative, into their diet, and that helps. But that's in the end. They try not to do that. Now, peptic ulcers, you're thinking, kids don't get ulcers. Oh, yes, they do. They're little worry warts. They worry about mommy and daddy and sister and brother and the dog and the rabbit and the whoever. And they do and can get ulcers. So we treat it just like we treat adults. There's no difference. The first thing they'll put them on is something like the ranitidine or the Pepcid. I know ranitidine was called off the market, but your book still has it written in there. But ranitidine, same thing as Pepcid. What does it do? It reduces the gastric acid production. So it's less acid eating at the lining of the stomach. What else? We're going to put them on a bland diet. We're going to decrease all the spicy pepper out of their diet. So eating correctly, adding a medication, and then adding it till we get it taken care of. They even get, as they get older, Mylanta and Maalox and all of those things if they need it. But they start out easy, and the easy they think is just with this ranitidine. And their outcomes are good. And especially if we know it's something emotional going on, parents can talk with their kids about it. Like, what are you worried about? Some kids will talk, some kids won't. Maybe they'll talk to Nana and not mom and dad, but as long as there's somebody. Now, there's many types of hepatitis. It's due to many different things. We know that these kids, good hand washing for us always, but we do universal with all patients today. Now, a diet. How are we going to feed these kids? Well, When you don't have liver working properly, you don't have good fat digestion. There's no enzyme produced. It doesn't have any bile going, nothing that's going to help digest fat. Fat causes bloating, swelling, and abdominal pain. So you don't want fat in your diet, or as low as possible. You want high protein, high carbohydrates, because you want them to get the best nutrition they can. So that helps with what they call muscle wasting, especially when you're talking protein. Now here's that Hirschsprungs I was talking about that causes constipation. If you look at that picture in your top right, you see that big out patch there at the bottom? That's swelling of the intestines. It should be narrowed, but it's not. There's no nerves. Aganglionic megacolon. Aganglionic means no nerves. So there's no peristalsis. They don't feel it stretching and they don't feel pain. What will we see as a nurse? Well, we might feel it in their abdomen, this big pouch, okay? But sometimes you see that little tiny little ribbon that goes to the rectum? Just like you would take icing and put it on a cake and squeeze the thing and put ribbon type designs on your cake, you might see ribbon type stools come out, may or may not, okay? So that's one of the things, Hirschsprungs, ribbon-like stools. So how do we treat this thing? Well, we've determined they're constipated. We've done the x-ray. It is Hirschsprungs. Well, we're going to do the x-ray. Of course, a barium enema. We got to test it out and we'll do a rectal biopsy. What does that biopsy show? Well, it shows there's no nerves in the tissue. So we know it's aganglionic megacolon. So it's a two-part surgery. The first part is, so we have to take out that piece of intestine that doesn't work, that has no nerves, that's distended. And we're going to bring a piece of the front of it up and make a colostomy. That colostomy will be there up to about a year or less from birth, so that at least fecal contents can come out the way it should. And then they'll re-anastomose it later on. As I said, usually within the year, sometimes within 6 months, all depending on the child. Acute appendicitis, kids, from school age to your adolescence, this is a very common abdominal pain. What do you see? This kid is going to be usually, many times they're walking in, their hand on their right lower quadrant, they're bent over and they're limping on their right leg. And you look at, go, that's an appendix. You sort of can tell by the way they look. They will have that positive McBurney point, just like adults. The same rebound, all of that, just like adults. So one of the things with appendix, yes, they'll send them to ultrasound. It's there. They'll be scheduled for surgery. You start your IV, NPO. They go to the OR. If that pain stops and they don't hurt anymore, that appendix has ruptured with all of that, debris and contents into the peritoneum. And this is all bacteria. This is all waste. This is something that shouldn't be in the peritoneal cavity. It goes in and those intestines are angry. They're red. They're like all of this caustic material has touched them. So the physician goes in, the surgeon tries to clean it, wash it out, do what he needs to do, sew them back up. And now they come to us. How do we treat them? Well, their intestines are angry. They can't tolerate anything going through them. So they're NPO with IV fluids. They're going to get IV antibiotics because it's an infection in there. And they're going to be getting an NG tube. And the NG tube is to keep the intestines empty because that intestines is so angry. It hurts. So of course, pain control, especially if you want them up out of bed doing good pulmonary care. You don't do pain control, these kids ain't going to move because it does hurt. And the other thing is that intestine was full of infection and you've closed up an incision. That incision was two dirty pieces coming together to close. the chance of that to dehisce are huge. So make sure you're assessing that wound because it can come open. Intussusception. Intussusception is your 3 months to 3 years old. Kid comes in with sudden onset of abdominal pain, tense abdomen, legs and arms are going and they're crying and you cannot console them. It hurts. The intestines suck up into each other. So you have the intestines that it sucks up. Now, what would you look for? Currant jelly in the stool with maybe some blood streaks. You might see it in their diaper or even in their underwear if they're potty trained. It sort of pushes it out. It's one of those telltale signs. So what do we do for this? Well, we figure out this is what's probably going on. We're going to get them over for an ultrasound. Now, the thing is, many times they spontaneously come out, and you'll know that because the kid don't have any pain anymore and is running around. So don't send them for ultrasound because there's nothing to look at. It's when it's, into each other, that intussusception is full, that you do the ultrasound, you can see it. So how do we treat this? We want to keep the intestines out. Well, you increase the fiber in their diet and send them home and tell them if it happens again to come back in. Sometimes parents wait too long and that intussusception is sitting there and it swells and you can't move it. And this child might need to get an air embolus where the radiologist pops it open by an air enema, or if it can't come out, they'll be sending them to surgery. They'll take a piece of intestines out. So again, getting them there as quick as they can is good. Many times these kids do resolve on their own and they do well. And the outcomes is no long term. If they pop out by themselves, it's just part of that being young and the muscles and the fibers in there. Mecyldiverticulum. Now, the small intestine sometimes have these little out patches of like little tissue, and they call that a diverticulum. And inside that diverticulum is a blood vessel. And sometimes with food sliding through or whatever, it rips and it's going to cause bleeding and quite a bit of bleeding. So what do you see? You're going to see painless rectal bleeding. You might have a little bit of abdominal tenderness, but nothing that matches the amount of blood you're going to see in the toilet with stooling. So how do we treat this? Well, once we figure out what it is by CAT scan or ultrasound or that radionuclide study, they're going to need surgery. And they go in and they take that diverticulum, tie off that bleeder, and they do well. And the outcomes are really good on these guys. IBS, mouth to anus, any inflammation anywhere. Ulcerative colitis, Crohn's. The ulcerative colitis is segments of the intestines, and Crohn's disease. And this is an inflammation of the lining of the intestines. And usually medical treatment, they're placed, sometimes it's so bad, they're on some sort of biologic, Remicade, Humira, one of those, or sometimes it's just steroids used when they need it, but it's also much diet. What they put in their body, the foods they eat can really upset it. Sometimes if it gets bad, they've got to take pieces of intestines out, but it's nutrition that really helps the best. And of course, steroids also help with the ulcerative colitis and the Crohn's. Short bowel syndrome is when an infant loses a large portion of their intestines, usually small intestines. I saw one little girl named Jessica. She was a triplet, and she was a kid who had cardiac condition. And she came in for her second stage surgery. And after a second stage, she developed what we call necrotizing enterocolitis, NEC. And it's where a piece of the bowel dies. I think it's due to like hypoxic episode, and the bowel doesn't get oxygen and it can't work, and then the nutrition is too much and it just dies. Well, this girl had 48 centimeters of her small intestines removed. She only had about this much left. So what absorption did she have? So you can imagine the big problem with her was nutrition. I mean, how does she absorb what she needs? So they put in a Broviac. She got hyperalin lipids at night, all the extra nutrition we can give. And during the day, to keep nutrition, because you can't keep eating, you can't keep up with it. She also had tube feedings that also used to help her. So this girl, I met her when she was 18. She didn't have the Broviac or the G-tube anymore. She could orally take what she needed, but she was skinny, of course, because, you know, her whole life, she's trying to keep up with her nutrition. But of course, high calories, high protein, very important for her. Now, gastroschisis, or sometimes you're going to see bladder exstrophy, are two conditions where either the stomach, gastroschisis, is born on the outside of the body. Now it's connected, but it didn't get inside and the skin didn't close. So that is gastroschisis. Our job, keep that inside tissue clean and healthy and infection-free. The surgeon comes and tucks it in every day, and finally he can close it. And that's how you treat it. Now, hernias. Have you ever seen a little umbilical hernia? You push it in and out and it's soft and squishy. You've seen usually inguinal hernias on the older gentlemen. I see them a lot on premature infants too, inguinal hernias. And as long as you can smush them and they're non-tender, they're fine. But they become hard, painful, reddened. This is what is twisting. There's lack of blood supply. It becomes incarcerated or strangulated, and it needs surgery right away. And that's how you would treat it. And because you don't want to have that intestines die. Just untwist it, put it back in, mesh it, they do well. Now, one of the ones that you see in infants, newborns, is something called diaphragmatic hernia. The diaphragm doesn't completely form. So you have the chest cavity and the abdominal cavity. And the abdominal cavity comes up on the left lung, it beads upon it and pushes in with all the intestines up in the chest. You do not make a left lung because those intestines have stopped that growth. You will never have a left lung. Also, if you see it, it's pushing on that right lung. So at birth, these kids are extremely ill. How do you oxygenate like 1/2 of one lung? Oxygenate. So think of that. These kids usually end up on very high level ventilators, or they are put under ECMO, where they take the blood and oxygenate it and put it back in. I've seen it done both ways, and they actually do surgery at the bedside. They're too sick to bring to the OR. So they'll take and put a mesh and put it down, but these kids for life will have issues with respiratory. You have to be very careful with them. Malrotation, volvulus, this is either you have the intestines around an artery that pinches it, which causes cell death, and it could rupture and perforate, which causes peritonitis, or it ties in a knot. I mean, you've seen umbilical, you know, the umbilicus on babies tied in knots around their head in knots. Well, intestines can do the same. And it presents, looks sort of like intussusception, sort of looks like an appendix, but it's in like the upper left corner usually. So again, they'll do the x-rays, they need to go to surgery with these. Now I said there's times where an anus, you don't have it. So it's called an imperforated anus. And that's why you do a rectal temp at birth. Yeah, you want to have a real accurate temperature, but you want to see, do they have an anus? Now, if they don't have an anus, where's all the gastric juices going to? So they need to get a colostomy as soon as they can. Another thing that can happen is fistulas between the bladder and the intestines, or it could be the urethra, and you'll see stool coming out of urine, or you'll see urine come out of the anus. So being aware where these, or even out of the vagina. So you have to be very careful looking at where is the stuff coming from. Sometimes it's the nurse who finds these things. You're like, look, there's stool coming out of this little girl's vagina. Something's going on, right? So they'll find the fistula and they'll fix it. And vomiting, common with kids, right? Every kid spits up. Every kid tends to, burp and lose a little bit. So it's teaching parents how to burp the kid well, sit up after feeds, not to overfeed. And then sometimes it just dribbles. So maybe it's just an intolerance. Maybe it's food intolerance. There's all different things why. Or the kid is just having a gastric upset where they're vomiting because they have like an acute enteritis type thing. So the first thing I ask when I get an infant who's vomiting, especially the very young ones, under 3 months, do they dribble or do they forcefully vomit? There's a difference, and I'll go into that in a little bit. But if they're just dribbling and they're vomiting like they're retching, just started yesterday and they've had 6 vomits already, number one, make sure that we check for signs of dehydration. First of all, what? You're gonna look at Fontanelle if they have one, heart rate, blood pressure, skin turgor, capillary refill, ask about wet diapers, all of these things. And we want to know what their electrolytes are, metabolic profile. And again, we're going to start an IV when they're dehydrated with normal saline, never bolus with dextrose, never add potassium until they urinate or have that results. And you're not going to feed them until we get some antiemetics in there, and then slowly we introduce. Now, kids eat everything, right? From grandma's meds off the dresser to, ooh, those vitamins are good, climbing up on the counter and getting them out and sitting there and eating the whole jar of Flintstones chewable vitamins are so good, right? Well, vitamins are not that bad if they don't have iron, because what you don't need, you'll just urinate out. It is with iron that you have a problem with. Also, what if it's those Tylenol? They're chewing those little chew tabs and they're chewing those Tylenol. That could be toxic, hepatotoxic Tylenol, right? Sometimes I've seen rat poison they think they got. Teenagers with those Tide Pods. I mean, they're ridiculous, eating those, which created a lot of GI problems. And these things need good monitoring. Like the rat poisoning is like giving Coumadin. It's going to thin their blood. We need to monitor lab values and coagulation studies. If you have iron, you might need iron chelation, doing lab values. Many of these kids who eat these things could end up in ICU being monitored very, very closely. Now, reflux. Gastroesophageal reflux, stomach to esophagus. And we know that little kids do it, and how do we treat gastroesophageal reflux, that reflux in little infants? Well, even though there's no nutritional value, we put a little bit of rice cereal in their formula because it holds it down, it thickens it. That's as easy as we treat it. And that's the best way. You might see rice cereal in their stool, but it's holding down their nutrition. Older kids, they're going to have this chronic cough. They're going to have this cough, 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 cough going on. And you might feel them with that burning in their chest, that heartburn. And that's going to tell you probably this is reflux going on. So, of course, medically, you try all the meds. Do everything you possibly can. If that don't work, many times they need to go to a surgical intervention. And it's called a Nissen fundoplication. They take the end of the stomach and pull it up so that you cannot have the food go up. So it holds it down in the stomach and prevents the esophagus from getting irritated and esophagitis. So it does work. Now that other type of vomiting that I was talking about, normal vomiting, it sort of dribbles out. Then there is that age 3 weeks to about 3 months. And they vomit and it is across the room, like hit your shoes on the other side, like exorcist. Oh my goodness, my kid is possessed. It is really, really significant. You know, the first time I saw it, I was like, okay, here's the garbage can. Let's aim for it. So what do we do? When I see that, usually the parents are holding this child because they're young. They're under 3 months old. I put my hand underneath their abdomen, right by their breastbone, and I just really just gently feel. You can feel like a marble or an olive. It's hard. And what that is a pyloric sphincter, which empties the stomach into the small intestines, is musculature. And it's hypertrophic, and it's small, it's narrowed. Formula can't go down. So what happens is it builds up in the stomach, and all of a sudden the kid can't take any more, and poof, across the room like an explosion. These kids are immediately hungry. They're not eating. It's not going down. So they're going to want to eat again. Now, what do we do as a nurse? Kid vomits across the room, projectile. We feel this little olive, this little marble up in there underneath their sternum, and you go, okay, kid needs surgery. Make the kid NPO. And because this is a newborn, they're going to need sugar. Start an IV immediately because they need to go to surgery, but we know we need to supplement calories. Everything's coming out. So we're going to give them an IV with a little dextrose in it. Nothing to eat or drink because we don't want them to aspirate. Post-operatively, they take and they open up this type of band, this hypertrophic band, open it up. There's no problems in the future. And when they wake up, they can start drinking. And usually they go home within a day or two. Cleft lip, you see it at birth. Could be lip, one side, two side, and it could be palate or no palate or palate and no lip, any part of it. Now, if there is a lip that has a cleft, we need to try to close that as soon as possible. Remember, what do infants do? They soothe themselves with a pacifier, or even eating with their breast, or drinking with a bottle. That is self-soothing. So they need to close it. So they'll do a plastic closure. And they put this Logan bar there so they don't smush their face into the bed and open up this lip because it is very small, little tiny sutures that are in there. So that's done at 2 to 3. And if you notice, we put elbow restraints there so they can't touch it also. So it looks like any of these, and this is a picture in your book too. And then there's a palate. It's the top of your mouth. There's hard and soft. Sometimes it's the whole way through. I've seen just a palate without a lip. And the thing with the palate is we need to close it usually before 1 year old. And the reason is speech. If we don't close it sooner, they talk like this because they can't make the sound. They don't have that top piece to make the sound of, pronunciation. So getting them fixed as soon as they can, very important. These kids do great. There's no outcome. They do well. They're fixed. So problems with them is feeding with this cleft lip, this cleft palate. This is a Haberman bottle. Actually, a mother invented this. And that top part that sticks out, you turn the bottle over and it fills up. And it's really soft and malleable, pliable. So you put the nipple in the child's mouth, and as they suck, you squeeze lightly. And they can drink. So they're getting that suck and swallow and that soothing. And they do really, really well with it. They love it. breastfeeding is hard, but some parents, even, you can see this little girl here does have a cleft lip and she's breastfeeding, but I'm sure the mother's squeezing her breast as the kid is trying to nibble on the breast. And remember, we're always worried about nutrition. Are they getting enough? How do we measure nutrition? Well, breastfeeding, wet diapers, height and weight, right? Wet diapers at home. You're getting those 6 wet diapers a day, you're getting enough to drink. Going to the doctors, you're gaining weight, you have enough nutrition. Now, at birth, there's a congenital defect called esophageal atresia. Remember, A is without. So you have an esophagus, but it's connected to nowhere. It's a dead end. So you eat, it's going to come back up, right? There's nothing there. Remember, if it comes back up, you always have a chance of going into the trachea, aspiration. That's our big concern. But there's also a condition, and sometimes they're together, tracheoesophageal fistula. There is a tube from the trachea to the esophagus. So you eat, go down the esophagus, goes across the fistula into the trachea, and now you have aspiration. So what do you think the treatment for this is? Well, number one, we've got to figure out the habit. What are you going to see at birth? Well, this kid can't swallow. And if they swallow, it's going to go in their lungs. They're going to aspirate. So they're going to be coughing and sputtering, right? They're going to be foaming at their mouth because they can't swallow because it's going into their lungs. They're having aspiration. So as a nurse, head of the bed elevated on these children and suction at the bedside. And nothing, not even a drop of water in their mouth, because it goes directly into their lungs. So preoperatively, nothing to eat or drink. We're going to start an IV, and because of this, they're still swallowing some of their own spit. They're still aspirating. We're going to put them on antibiotics because we don't want them to get an aspiration pneumonia. And these kids are healthy. They do well once it's repaired, but it is scary. These kids, again, they can't eat or drink. Remember, newborns all need that pacifier, whether they can eat or drink, but you put nothing on the pacifier. You cannot even put sugar water because it's fluid, which will go into their lungs. So that's that part. I told you it's a lot of different things, especially in GI when you talk about children. So who wants to win a Cahoots tonight? Nobody today? All right. So let's see who's going to win today. All right, let's get going. There's a lot of select alls, I'll warn you. Starting with one. All of the following are symptoms of dehydration in an infant. And then I'll ask you, does it really matter, infant or adult? Dehydration is dehydration. The only difference might be the vital signs, right? In an infant, it'd be a heart rate of 200. And an adult, it could be a heart rate of 120. So there is that difference. They have a decreased urinary output, but yes, those are the things that you see. You also see sunken eyes and crying without tears. What is priority treatment for a child with dehydration due to profuse vomiting? So IV fluids, if they're vomiting, how are you going to give them oral? They're not ready. So you are going to be giving them the IV fluids. You're going to give them an antiemetic and then wait a little bit and then very slowly try oral. What is a treatment for an infant with diarrhea lasting for 4 days? Now, what's the difference between vomiting and diarrhea? Well, vomiting, you're vomiting. You can't drink. But diarrhea, can you drink? So when you have diarrhea, they will go to giving oral electrolyte solutions, Pedialyte, Powerade, Gatorade, depending on the age. Infant, absolutely Pedialyte. They don't want that extra sugar. It's too much in the other ones. But we'll start with Pedialyte and increasing the diet to solid foods because we want that stool to have something in it, just not water. And as I said, they treat it with a probiotic. That's how they treat diarrhea. What acid-base imbalance might you see with a child that's having profuse diarrhea? I think you see almost every cahoots I do, you're going to see an ABG question of sorts. So if you're looking at diarrhea, what sort of liquid is excreted? And if you think about that, it's all the alkalinity of the enzymes you're getting rid of. So you don't have alkaline. So it's going to be metabolic acidosis. What if you were vomiting? You're getting rid of acid, stomach acid, right? So you have no acid. Then you'd be metabolic alkalosis. That's how you know the difference. I'll multi-select. If an infant's not past meconian stool in the first 24 to 36 hours, you would assess for what? So, you may look for electrolyte imbalance, but what are you concerned about? No stooling. That's what you're looking for. Is it a thyroid problem? Is it cystic fibrosis? Is it Hirschsprung's? Electrolyte imbalance is secondary at this point. We want to know why has not this child stooled, and we need to correct it. Especially when you're looking at hypothyroidism, they need that thyroid hormone immediately. It's all about cognition there. Deficiency of vitamin D causes. Our GI tract, absorbs all of these vitamins. So lack of vitamin D causes rickets. Rickets has to do with bones. So, vitamin D, you need to have strong, healthy bones. Scurvy is actually vitamin C. A multi-select. What treatment can a nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? They've got GI to the max. They call that gastroenteritis, right? So we're not going to do anything by mouth. This kid is unable to eat or drink. What we're going to do is check that electrolytes, that basic metabolic profile. We're going to start IV fluids and we're going to rehydrate them. And you know, how do you know if you rehydrated enough? Well, number one, the heart rate's going to come down. That's the first thing I'm going to know. And they're probably going to start to urinate. I'll multi-select. What nursing management would you anticipate for a child with a ruptured appendix postoperatively? Remember, all those toxins spewed, got into that peritoneum. Didn't get it quick enough. So when you're talking ruptured appendix, you definitely don't want complete bed rest. You want them up, walking, sitting. You want to prevent all of those complications, okay? Number one, IV antibiotics. It's an infection. And that NG tube is to keep that intestines free from anything. It is angry. All of those toxins have really made it upset. So we want to keep it empty, especially gastric juice, right? And then because that incision was a dirty incision closed, we want to inspect it, make sure it doesn't open. Passage of urine usually at night in children who should have voluntary bladder control. And that is called enuresis. Now, there's two things here I want to describe to you, epispadias and hypospadias. Epispadias is on a male where the urine doesn't come out the tip of the penis. It comes out from somewhere on top. There is no hole on the end, so it doesn't open the whole way. Hypospadias is on the bottom, so ventral dorsal, right? What they do is they take the foreskin and they use that as tissue to reconstruct and get that meatus to the end of the penis. Once they do the surgery, they put a catheter in there to hold open the lumen of the meatus and the urethra. That catheter stays there. We do nothing to it. We just keep it inside a bladder because we're measuring urine output, and urine comes out. And it usually they take it out at 7 or 10 days. It is a really big procedure. They have to splay open the penis to do this. So it's under general anesthesia, but these kids do really well with it. They like to do it before potty training. Multi-select. What is Hirschsprung's disease? Hirschsprung's disease is that aganglionic megacolon, yes, because that means no nerves, and congenital absence of parasympathetic ganglion cells, no nerve cells. It gets big, no peristalsis, it don't work. And what do we have to do? Go in there, find this out, do x-ray, biopsy, barium enema, and then we take it out, make an ostomy, and then close it up later on. 2 stages. I'll multi-select. When teaching parents about Hirschsprung's disease, the nurse would include what? Like, what is Hirschsprung's? I've never heard of this. You know, parents really, really rely on nurses, do a lot of teaching. And it's actually okay to say you don't know, but to find out and let them know. I've done that in my career, why not? But it causes a bowel obstruction because nothing can go through because it can't get through, the anus because it's big. It also is that two-stage surgery, ostomy, and then they close it up with a reanastomosis. And we need to, of course, monitor their bowel habits, making sure that they're stooling. We do not. So the last thing we do is treat with laxative and enemas. We try something natural first. And Hirschsprung's usually doesn't need it. What type of stools would an infant with Hirschsprung's disease have? Remember, big outpatching that goes to the tiny little narrowing to the anus. And it's ribbon shaped. It's like taking an icing bag and squeezing it, and that little shred of ribbon comes through. That's exactly what this looks like. Sometimes you see it, sometimes you don't. Which is a condition that occurs mainly in children when the intestines telescope into themselves, causing sudden onset of severe abdominal pain. And I'm telling you, my heart hurts for them. Their legs are going, they hurt. And that's intussusception. It goes inside intussusception, like a telescope. Gastroesophageal reflux disease, GERD. What's that? So reflux is when the stomach, stomach, esophageal, esophagus, it goes up. What's our big concern with reflux? Aspiration and aspiration pneumonias. How do we treat it? Just like adults. Let's start with some, Zantac, some Pepcid, one of those first. Sometimes it's just diet. It's putting rice cereal or thickened foods. Sometimes that's it. But it's a multi look at this. It's treated many different ways, and every way works. Separately, each kid is different. And I think that's why I like kids, because some kids, it works with just some rice cereal. Some kids need 3 different things. Some kids need 2. You'll see more in adults. It's more one sort of treatment is what works the best. Inflammatory bowel disease involves what? IBS. When I think of IBS, I always think it's mouth to anus, anywhere in between. It's all of the above. All of the above. Anywhere in the bowel can be inflamed, and anywhere can cause pain and misery. What would the nurse be looking for when a patient has a meckel diverticulum? And we call it painless rectal bleeding. There might be some slight tenderness in the abdomen, but this is up in the small intestines, and they need to go do surgery, and they need to remove that diverticulum. It's that piece that's just teared, and blood is just pouring into the intestines. And it can create problems. A lot of blood can come out, so it needs to be attended to surgery. A 6-year-old goes to the ER due to abdominal pain, fever, and vomiting for the last day. What assessment's priority? What do you need to ask? What assessment do you need to know? What's priority? Tell me, where's the abdominal pain? Is it the right lower quadrant? Is it in the appendix? Is it over the umbilicus? Is it up, underneath the sternum. Where is this pain? It will determine how you treat these children. Priority is, where is the pain? What would the nurse expect to see in an infant with biliary atresia? That means nothing, no connection between the liver and the common bile duct. There's no secretion of enzymes going in to aid with digestion. What do you see? And what does this, the liver do? It helps with fat digestion, right? So you're going to see this, there's no bile coming. This color of the stool becomes like very clay, whitish gray. And because you can't tolerate fat, you have this big abdominal distension and even a lot of gas you'll see in there. And that's specific to biliary atresia. Now you're going to see them turn yellow and the sclera, etc. But initially, that's what you see. What structure of the mouth can be impacted by cleft lip and palate? So it's anything, hard palate, soft palate, lip, one of them, two of them, or, just all of them. Cleft lip repair is typically done when? And remember, it's so important that kid can put its mouth around a bottle or a pacifier, because we know that's what soothes these children, that self-soother, the mouth, everything in the mouth. So it's somewhere between 2 to 3 months, okay? First thing is that. Cleft lip is after, cleft palate is after that. So when does a cleft palate repair typically occur? And that's about 6 to 12 months. We want to get it before they start talking. Yes, very good. Esophageal atresia. So remember, A is without. So there's no opening to the stomach. So atresia, there's nothing. There's just an esophagus. It's a lack of opening. What are the classic signs of esophageal atresia and tracheoesophageal fistula? What would a newborn show you that makes you look for this? So they're not getting rid of their secretions. It can't go anywhere. They're swallowing it, it's going into their lungs. So they are cyanotic, they're choking, they're coughing. How do we treat it? Elevate the head of the bed, have suction at the bedside. Nothing, nothing, nothing by mouth. I'll multi-select. Neonate suspected tracheoesophageal fistula. Nursing care should include so we want the head of the bed elevated, nothing to eat. Remember, they're always, taking their own saliva and swallowing it. They are aspirating. So IV fluids and antibiotics, because they are swallowing their own secretions as much as we could suction, because you can't suction that much. So antibiotics are put there too with this child. A 5-year-old child with complaining of epigastric pain and a persistent cough. What would you suspect? That cough, what is it? So you're suspecting that gastroesophageal reflux. That cough is that little bit of aspiration that's going on with that food coming up the esophagus, okay? And that pain is part of that burning, that esophagitis that they're getting. What is ranitidine used for in a child with peptic ulcer disease? Ranitidine, Zantac, Pepcid, famidamide, which one? What is it used for? What does it do? And it reduces gastric acid production. So there's less acid, the stomach has a chance to heal. And again, we treat this just like adults, same medicines in pediatric doses. We change the diet, just like with adults, with those non-spicy things, same thing, but on the level of the kid and the age of the child. Signs and symptoms of hypertrophic pyloric stenosis. What is it? Remember, you feel that little marble or the little olive right underneath the breastbone? That is the pyloric sphincter that's thickened and muscular, and you can actually feel it there. What's another sign and symptom of hypertrophic pyloric stenosis? The one that I tell you to watch out for. Get the garbage can ready to catch it, right? Projectile vomiting. So you get a kid, comes in, very young, under 3 months old, parents say they're vomiting. First question, are they vomiting like this, just a dribble, or is it across the room? That's going to tell you the treatment that you need to do. Preoperative treatment of pyloric stenosis include? So now they've told me it's projectile vomiting. I know this kid's going to go to the OR. They're going to get an ultrasound. We're going to look at it, say, yes, definitely it is. This kid's going to go to the OR. So NPO, because they're just going to keep vomiting and we don't want them to aspirate. And we're going to start IV fluids to make sure that they get the sugar they need, because these are young infants. You can't leave them without eating for a long period of time, no more than 2 hours. What does a celiac disease affect? So when you think celiac disease, think of nutrition, right? It's all about nutrition. What area covers nutrition? It's your small intestines. That helps you think of where it's going to be. Celiac nutrition, where part of this covers nutrition, the small intestines is the one that, absorbs it all, or most of it. If you have celiac disease, what should you eliminate from your diet? And that's wheat, rye, and barley. So a lot of this is bread and breadings and macaroni, spaghetti noodles, those sort of things. Things the kids like, right? Breaded chicken nuggets and macaroni and cheese, but they do have gluten-free now, so they have it. A multi-select. Vitamins that children with celiac disease are prone to lose are. And this is why these kids need supplements. This is why these kids are small and they do need extra calories and protein in their diet because of this. So all your fat solubles, vitamin C is water soluble. A, D, and K are all fat solubles. And depending, they will give supplements. What foods would you select for a child with celiac disease? Remember, anything with breading or made from breading stuff. No. So which one there looks good? So bacon omelet, eggs, they can have cheese, they can have milk, they can have fruit, vegetables. They just can't have that breading stuff like macaroni and cheese, French toast, or toast. But there's many other good choices. Thymosis. It's one of those concepts I don't cover in the PowerPoint, but I can cover it in one slide. And actually, my grandson, this was his issue at birth. The grandson knew how much I talk about him when he's older. Oops, sorry. It's when the foreskin is tight and you can't pull it down to clean, because we know we need to pull it down daily to get the schmegma out to prevent urinary tract infections. His foreskin was so tight, I couldn't even get down the tip of it, not even. So they ended up doing, within the first month of life, they did a circumcision. Not because we like circumcisions, but because of the phimosis and the potential problems from it. So phimosis, it's too tight. It can't come down, because we need to teach parents to pull it down once a day minimum and clean it good. Soap and water, that's it. What is a hydrocele? And I've seen this in adults, and I've seen it adolescents, I've seen it in infants. And a lot of times they'll come in complaining of pain in their testicle. Sometimes they come in complaining that the child was incontinent and hasn't been in a long time and has a little pain in the testicle. And it's the fluid which irritates the testicle, and they treat it with antibiotics, and they do very well with it. What is cryptorchidism? Well, I think you see it has something to do with the testicles. What does a pediatrician do first visit for a male infant? It's going to check for testicles, right? Is it one or is it two? Cryptorchidism is when one or both, they haven't come down and you can't feel them in the testicular sac. Now, one of the things with males, if they're in a cold environment, their testicles suck up, right? So we need to examine them in a warmer environment. And the testicles don't like to be put up there too long because they'll die, because it's too warm up in the body. So they need to come down. So most of them come down by themselves, but sometimes they need a surgical repair to get them down, or else they're not going to produce sperm. And, you know, a male is going to want maybe to have babies in the future. You suspect an infant with cryptorchidism. How would you examine the infant? So again, put them in a warm room. We want those testicles to be able to hang as well as they could. And you always ask, have we ever felt that testicle before? A hypospadias is, remember, it's this one. Epispadias, hypospadias. It's just knowing terminology. It is on the ventral side, hypo underneath. On top, dorsal is your epispatus. I'll multi-select. How is a hypospadias corrected? I told you earlier. So we use the foreskin, and then a stent's put there when it's done to keep the lumen open, and the urine drains from there. And we don't touch that stent, we just keep it inside the diaper so we can measure urine output. That's it. And actually they do very, very well. They like to do it before they get potty trained. What is bladder exstrophy? Bladder exstrophy is when it doesn't close, so it's midline, the bladder's open, and it happens intrautero for sure during the development. And our concern as a nurse is to keep it clean and dry and to protect the integrity of the tissue. The bladder still works. You still measure urine output in a diaper. It's all okay, but it's on the outside, not inside. What is a priority nursing care for an infant with bladder exstrophy? Again, tissue integrity, we gotta keep that bladder healthy, the tissue good, so that when we can put it back in and close it back up. And they usually have no problems in the future with it once we get it back in. What are the clinical manifestations of nephrotic syndrome? Remember, it is not renal failure. So you're losing proteinuria, hypoalbuminemia, low serum albumin, same thing as hypoalbuminemia. And because of that, we have all the fluids going interstitially. So it's all the above. Children with nephrotic syndrome are often given which medications for fluid overload? So remember, you have interstitial fluids. You need to pull it into the intravascular. And then you need to give a diuretic and get rid of it. So what do we do? And we know that this works because we're going to see a really good increase in urinary output. Albumin, we replace the protein, it pulls out the fluid intravascularly, give a LASIK, poof, and you start urinating and you get rid of all that peripheral edema. And we know it works when they're urinating. What is used to treat nephrotic syndrome in children? We're going to treat it with prednisone. Remember, we're going to look at salt restriction, fluid restriction, and we're going to monitor intake, output, and daily weights on these kids. And they're very susceptible for infections. A child's admitted with acute glomerulonephritis. What recent illness could validate this finding? We know acute glomerulonephritis and rheumatic fever are due to an undertreated strep infection or just a sore throat that they say. So it's all about that strep, and we're going to treat it by treating the strep. What is the priority nursing care of a child with nephrotic syndrome? Remember, nephrotic syndrome is all about fluid balance. How do we monitor fluid balance in children? Daily weights, strict INO, but daily weights are going to say, are you doing better, staying the same, or doing worse? Are you retaining more fluid? Why is erythropoietin used in chronic kidney failure? It's a question for adults too. It's used in children, but again, it's given in a dose, milligrams or micrograms per kilogram. And it's to increase the production of red blood cells, just like adults. A multi-select. A child with chronic kidney disease can have renal osteodystrophy. What can this do to the child? Has to do with vitamins, right? They're losing them, they don't have them, or they're accumulating too much and they can't get rid of it, and this causes problems. Osteobone dystrophy is problems, abnormalities. Also, growth is stunted, growth retardation, and it's high parathyroid levels. Well, parathyroid does what? Calcium. So your calcium's too high, and this can cause all of these problems. A diagnostic finding of acute glomerulonephritis may be what? So you don't really know what's going on, so you sort of do some lab tests and you try to figure out what it could be. This one hits the nail on the head. What is acute glomerulonephritis caused by? It's caused by a strep infection. An ASO titer is an anti-streptolysin. It looks at strep. So it's the perfect test to be done when you're unsure, or the parent or the patient doesn't know. What complication of peritoneal dialysis is most important? Remember, peritoneal dialysis, that's your kidney, and we need to keep that kidney working. And the biggest complication that we do not want is abdominal peritonitis. If it's inflamed, it's infected, it's not going to work, and the buildup of toxins will happen. So change in that color of a flow, we're going to call the doctor now, and they're going to order antibiotics. So which clinical assessment is most important to report with a child diagnosed with an acute kidney trauma? I had a kid who was like 8 years old, was playing hide and seek. He was running around the corner and went backwards and went right into a trailer hitch. Have this huge, like really dark, purplish ecchymotic area on his back, right at the kidney. So they did labs. His potassium was 7.8 or 4. I mean, it was way up there. So when you look at kidneys, that's what you look at. And basically, he had fractured his kidney with the force of the hit. He's going to be okay, but he needed to be watched. A multi-select. Why should the nurse anticipate for a child who just had a renal biopsy? Remember I told you renal biopsy and cardiac cath, there's a lot of good similarities there. But remember, renal has to do with kidneys and fluid balance. So we're going to monitor intake output. We're going to look at the dressing to see if it's saturated with urine or blood, and they will stay in bed for 24 hours. They cannot get out of bed. We don't want to dislodge that clot. What would you do if the fluid draining from the peritoneal dialysis has changed color and is now cloudy? It's not that yellow, brownish looking stuff. It's not clear. We're going to call the doctor. That is telling us something's happened. There was a break in technique. There's an infection. We need to get this kid on antibiotics. So we need to call the doctor to give me the order for antibiotics. And last question. What would the nurse provide to an infant that cannot eat normally? So they're NPO for whatever reason. They can't eat. You know, what do infants, how do they take care of themselves? How do they relieve stress? What's normal growth and development, right? We want to give them a pacifier. We want them to be able to self-soothe. We want that non-nutritive sucking. It's so good for them. Number 3. Annie, good job, Annie. Number 2, whoop, 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 whoop. Angela, good job. And Mia, number 4. Charity and B, good job, guys. You do have that matching sheet. It's going to help you with this stuff because it is pretty intense with the amount of stuff that's there. What I want you to do, sign your attendance attestations. Remember to send me your projects as soon as you get them. I will score them, send them back if you want to get a better grade. And I want to wish you all a very, very happy Thanksgiving. You know, as nurses, not every time you can be off every Thanksgiving. And I used to work Thanksgivings. Why? I wanted to teach my children. Thanksgiving is not a day in a Thursday in November. It's every day when you have a roof over your head, and you have friends and family and a food in front of you, and that is Thanksgiving. So I wish you all the best and gobble, gobble, gobble. Have a good day. Anything, let me know.
Thank you.
Thank you.